In this video, I'm going to talk about urinary tract infection. The definition of UTI is the growth of bacteria in the urinary tract, or the combination of clinical features and presence of bacteria in urine. Significant bacteriuria means there's a presence of more than 10 to the power of 5 colony-forming units of a single organism per ml of freshly voided urine. So these are some of the causative organisms of UTI, which includes E. coli, the most common one, and others are Proteus, Pseudomonas, Klebsiella enterococcus, and Staphylococcus saprophyticus or epidermidis. The clinical features are different for newborn or infant versus older children. For newborns, the features are more subtle, which includes fever, lethargy, and they might appear more irritable. And they might have vomiting and diarrhea. Some may present with prolonged jaundice, which means yellowish discoloration of the body or sclera for more than 14 days for term babies. And they might have poor growth resulting in failure to thrive and also poor feeding due to poor appetite. For older children, the clinical features include fever and lethargy. They might present with symptoms like frequency, always want to urinate, urgency, sudden urge to urinate, and also dysuria, where there is pain in urinating. They might present with suprapubic pain, which indicates cystitis, or loin pain, which may suggest pyelonephritis. And they might have cloudy and smelly urine. For physical examination, we can look at the general appearance and can plot the growth chart and also see their blood pressure to exclude hypertension, which may be caused by renal diseases. We can also do abdominal examination to feel for any distended bladder, feel whether the kidneys are ballotable, and also palpate for other mass. Can also check the genitalia and also perianal hygiene. We can also look at the back to look for any spine lesion like spina bifida, and also can check the lower limbs to check for any deformities or muscle wasting to suggest for neurogenic bladder. For investigation, we can do UFIM with culture and urine culture and sensitivity. UFIM to look for pyuria, and culture and sensitivity to know what is the causative organism and also to help in choosing a suitable antibiotic for treatment. Full blood count, we expect to see leukocytosis and neutrophilia, which means there is high white cell count with predominant neutrophils to suggest bacterial infection. Can do ESR and CRP, expect to be high, and serum procalcitonin expected to be high as well. If high, can suggest pyelonephritis, which will have a higher risk of renal scarring. Can also do blood culture before starting antibiotics. For imaging investigation, we can do ultrasound of the renal system, MCUG, the micturating cystourethrogram, or the MSA scan, the dimercator succinic acid scan, which I will explain further in the slides after this. So these are some of the indications of imaging tests. Ultrasound is recommended for all children less than 3 years old and those above 3 years old if they have these indications. So the indications include children above 3 years old with poor urinary stream, seriously ill with UTI, palpable abdominal mass, the creatinine level is raised, or there is features suggesting of septicemia, and if after giving antibiotics for 48 hours they fail to respond well to the treatment, and if there is infection with non-E. coli organisms. For collection of urine, there are a few methods to collect the urine. The first one is bag urine specimen, also known as clean catch specimen. For bag urine specimen, there is high contamination rate up to 70%, And if the culture is negative, it excludes UTI. If it is positive, it should be confirmed with suprapubic aspiration. So for those children who are bladder trained already, toilet trained, they can go to the toilet themselves. Clean catch is recommended. And the second method is catheterization. This method has a low risk of introducing infection and have higher success rate. And if compared to suprapubic aspiration, it is actually less painful. So it is widely used, this method. And the third method is suprapubic aspiration, which is a gold standard to obtain uncontaminated samples. And so how do we do this suprapubic aspiration? First, we lie the child in supine position on the bed. Then we insert a thin needle together with the syringe vertically in the midline, 1 to 2 cm above the symphysis pubis. And this can be guided with ultrasound to see the needle. And usually the urine is obtained at the depth of 2 to 3 cm of the needle. For management of UTI, it is different for acute cystitis and acute pyelonephritis. So for acute cystitis, we can give per oral trimethoprim for 1 week. And whereas for acute pyelonephritis, we need to give IV cefotaxime for 10 to 14 days. And for this pyelonephritis, we repeat the culture within 48 hours if there is poor response to treatment. We might need to change antibiotics according to the sensitivity, and it is recommended to continue IV antibiotics until the child is afebrile for 2 to 3 days, and then switch to oral therapy after the culture results are out. For example, can switch to oral cefuroxime, which we give for 10 to 14 days. That's all for my video. Thank you.